All right, so the second part of this section, we talked about cardiac dysrhythmias, and now we're going to talk about myocardial infarction and its little buddies, angina pectoris and shock. So we want to identify the causes and treatments for angina pectoris. We want to describe the basic pathophysiology of a myocardial infarction. We want to be able to differentiate angina from myocardial infarction, and what is shock and why can it happen in myocardial infarction. So there are lots of different things that can cause shock, but myocardial infarction is one of them. So we're going to go. So basically, angina and myocardial infarction are complications of coronary artery disease. So when your coronary arteries get filled up with junk, filled up with plaques, they're narrowing. And so angina pectoris means chest pain. And that's what it is. It's chest pain. So angina pectoris is where there's a deficit of oxygen to meet myocardial needs. It can be triggered by physical or emotional stress, like shoveling snow. When the coronary artery is partially obstructed, you're not getting enough oxygen to the myocardium to meet that increased need. Atherosclerosis is the most common cause of angina pectoris. It's relieved by rest and administration of coronary vasodilators. So the drug most used to acutely treat angina is nitroglycerin, and it's a vasodilator. So your coronary arteries are constricted, you take that and it dilates them, gets more oxygen to the myocardium. Makes sense, right? So myocardial infarction is where the coronary artery is actually blocked. It's not just slightly occluded. And you get ischemia, obstruction of blood flow to the myocardium, or infarction, which is a blockage leading to death of myocardial cells. So the degree of damage from an MI can go anywhere from a partial muscle thickness to a massive amount of damage. And the treatment is going to depend on the degree of damage. So in 25% of cases of myocardial infarction, death results from ventricular fibrillation. So historically, women are more likely to die of myocardial infarction than men. The classic symptoms that they've always taught us in CPR class of myocardial infarction: pale, sweaty, clutching the chest, pain radiating down the left arm. Those tend to be the symptoms that men have of myocardial infarction. Women tend to have slightly different symptoms. So women can have pain going up into their jaw. Sometimes they have a feeling that feels like indigestion. In general, women are more likely to dismiss their symptoms as being something else, and they don't go in and seek treatment. In the past, it's been more frequently that since women had less specific symptoms, even when they did go in and seek treatment, they go into the emergency room and they'd say, oh, it's nothing, go home. And then that person dies of myocardial infarction. So I'd like to hope that it's better now, that people are more aware. Sometimes the symptom can be as vague as like something's not right or I don't feel right. So you need to take those feelings seriously. We had at the hospital where I work, we had a long time trainer who trained our CPR. She was great, really funny, awesome. So here she is training all the healthcare professionals that she's trained for years, and she started having chest pains. And so what did she do? Here's an educated professional that knows what she's supposed to do and knows that you're supposed to get immediate care. She dismissed her symptoms to herself. She just said, oh no, this is fine. I'm having chest pain, but it's okay. And she went on teaching the class. Well, then all the nurses and people that were working with her noticed that something was not right with her. And they said, hey, wait a minute, this is we're taking you right over to the emergency room. So they took her right over to the emergency room, and she was having a myocardial infarction. So she says she thanks goodness that she trained all those people and that they didn't listen to her when she said, no, I'm okay. And they took her into the emergency room. So I can honestly see myself doing that. So no matter how much you know about it, it's easy to just say, no, I'm fine, and then have repercussions later. So the basic physiology of a myocardial infarction occurs when the coronary artery is totally obstructed. Atherosclerosis is the most common cause of this. A thrombus from an atheroma may obstruct the artery, or it could just be the plaque buildup. The size and location of the infarct determine the damage. The complications of myocardial infarction are sudden death, not a good one, or cardiogenic shock, which we'll talk about a little bit more in a couple minutes. So shock itself is inadequate perfusion of oxygenated blood from whatever reason. So with cardiogenic shock, the inadequate perfusion of oxygenated blood is caused by decreased pumping capability of the heart. And that can be caused by myocardial infarction of the left ventricle, cardiac arrhythmias, pulmonary embolus, or cardiac tamponade, where the heart is bleeding into the pericardium and it's keeping the heart from beating. So all of those can cause cardiogenic shock. Other things can cause shock. Inadequate perfusion of oxygenated blood. Hypovolemic shock is caused by loss of blood or plasma. Lots of different things can cause that. Vasogenic shock can be caused by sympathetic response, vasodilation as a result of sympathetic response. Anaphylactic shock, we talked about last quarter, and it's a increased systemic vasodilation and capillary permeability due to a severe allergic reaction because of the release of histamine. Septic shock is vasodilation owing to severe infection, which causes capillary dilation, and you get hypovolemic. So the early signs of shock are anxiety and restlessness. So, I mean, that could be anything, right? Like shock, you know. And it's caused, the reason you have anxiety and restlessness is because the hypotension, the low blood pressure or lack of oxygenated blood stimulates the sympathetic nervous system. So that causes anxiety and restlessness. We compensate for the manifestations of shock with tachycardia, so increasing the heart rate to get more output. Cool, pale, moist skin, because the sympathetic nervous system is going to divert the blood from the periphery into the central organs where they're more needed. Oliguria, which is the reduction of the production of urine. Thirst, because we're lacking fluid. And rapid respirations, because we're not getting oxygen to the cells. So anaerobic metabolism increases lactic acid secretion, which leads to an increased respiratory rate. So all of those things are compensating for the fact that we don't have enough oxygen or oxygenated blood in our system. Progressively, later signs, lethargy, weakness, faintness, metabolic acidosis can result from shock, and we all know that metabolic acidosis can kill you. The lethargy and weakness and faintness are caused by decreased blood flow and cardiac output. The metabolic acidosis is caused by that increased lactic acid and increased renal excretion of acids and production of bicarbonate, because we have that renal vasoconstriction and the renin mechanism and a decreased glomerulofiltration rate. So it's all tied together, isn't it? It's all tied together. So the kind of shock that you're going to see in a myocardial infarction is cardiogenic shock because of the decreased pumping capability of the heart. So these are all the different types of shock, again, that I just went through. So hypovolemic, loss of circulating blood volume, that can be caused by lots of things. Bleeding is one of them. Cardiogenic shock because of the inability of the heart to maintain cardiac output to circulation. Distributive, vasogenic, neurogenic, septic, and anaphylactic shock are all changes in peripheral resistance leading to pooling of blood in the periphery. So you have that capillary dilation that leads to pooling of blood in the periphery. So all those are a problem, right? So they can all lead to terrible things. So the early manifestations of shock: anxiety because of the sympathetic response, tachycardia, that's compensatory, pallor is compensatory, lightheadedness because we're not getting enough oxygen to our brain, syncope, fainting because we're not getting enough oxygen to our brain, sweating, and reduced urine output or oliguria. The complications of shock include acute renal failure. That's pretty serious. Shock lung or adult respiratory distress syndrome, also very serious. These are all things you should go into the emergency room for. Hepatic failure, paralytic ileus, stress or hemorrhagic ulcers, infection or septicemia, disseminated intravascular coagulation, which all this stuff can kill you, and depression of cardiac function. So shock is a serious medical emergency.